Welcome back to another Decode Healthcare Explainer. Today, we're tackling something that honestly trips up even the most seasoned medical coders out there, and that is evaluation and management services during the global surgical period. We are going to totally master modifiers 24, 25, and 57. These are the absolute critical codes you need to know for handling unrelated post-op visits, same-day minor procedures, and the initial decision to perform major surgery. So, here's our playbook for today's explainer. First, the global surgical package, then modifier 24 for unrelated post-op, modifier 25 for same-day EMM, modifier 57 for major surgery decision, and finally, we'll wrap up with the top audit red flags. Let's dive in. Section 1, the global surgical package. All right, before we get into the weeds with modifiers, we really need to lay down the foundation, right? The global surgical package. The key takeaway here is that a standard surgical package already reimburses the provider for typical preoperative, intraoperative, and standard postoperative care. It's basically a bundle. When a surgeon does a procedure, the payer naturally assumes there's going to be follow-up work, checking the site, managing standard post-op pain, and they've already baked that payment right into the original surgical code. You literally cannot bill a separate E&M for just expected routine healing. Now, the CMS classification for these packages is actually pretty straightforward. Minor procedures will fall under a 0-day or 10-day global period. Think along the lines of endoscopies, minor joint injections, or simple skin excisions. Major surgeries, on the other hand, like an appendectomy or a hip replacement, trigger a massive 90-day global period, and during that whole 90-day window, any routine care tied to that specific surgery is fully bundled into the original payment. Moving right along to Section 2, Modifier 24, Unrelated Post-Op. Okay, so patients obviously don't exist in a vacuum, right? What happens if they get sick with something completely different while they're still recovering from surgery? Well, that is exactly where Modifier 24 swoops in. This modifier signals to the payer that an EM service performed by the same physician, or even just someone in the same group practice, is entirely unrelated to the original surgery. You're basically raising your hand and telling the payer, hey, I know this patient is in an active postoperative global period, but I am treating a brand new, totally distinct problem today. For example, maybe you're managing a chronic condition like diabetes during a 90-day post-op fracture period. To put this into perspective, let's look at this quick comparison. Say your patient is 2 weeks post-op from gallbladder surgery, but they show up complaining of a UTI. Now, a urinary tract infection has absolutely nothing to do with gallbladder surgical healing, right? So you'd bill your E&M code with modifier 24. But here's the catch. You have to have explicit narrative proof in your documentation. You need a separate diagnosis code to prove you're treating a new problem, not just expected surgical recovery. If you try using modifier 24 for a routine wound check or a standard post-op pain evaluation, well, that's incorrect and it's going to trigger a denial instantly. Next up, Section 3, Modifier 25, Same-Day EM. All right, let's pivot to evaluating a patient on the exact same calendar day as a procedure. Modifier 25 is incredibly common, but honestly, it is also highly, highly scrutinized by auditors. You need to use it when your EM service represents a significant, separately identifiable visit that goes way above and beyond the standard preoperative and postoperative work that's normally included with a minor or major procedure. As you can see here, justifying modifier 25 requires some seriously robust clinical documentation. Now, interestingly enough, CPT guidelines actually say you don't strictly need a different diagnosis code to use modifier 25, but your notes absolutely must clearly separate the EM cognitive work, the assessment, the history of present illness, and the medical decision-making from the procedure itself. Oh, and keep an eye out for strict billing restrictions too. For example, there's a prohibition on attaching the HCP-CS code G2211 to same-day EM visits billed with modifier 25 unless you're dealing with qualifying preventive encounters. So definitely keep that in mind. Let's break this down with an example. Say a patient comes in for a thorough evaluation of chronic knee pain, but while they're there, they mention a completely separate complaint of ear pain. You evaluate it, diagnose otitis media, and decide to perform an ear lavage. That right there is a textbook use case for modifier 25. But, on the flip side, if the encounter was just you taking a quick look at a minor problem, like a skin tag, solely to decide whether or not to snip it off, that E&M is already built into the minor procedure code. You cannot just slap modifier 25 on there just for deciding to do the procedure. That brings us to Section 4, Modifier 57, Major Surgery Decision. Okay, so what if that same-day evaluation isn't just for a minor skin tag? What if it actually results in a massive, life-altering surgery? That's where Modifier 57 steps onto the field. This modifier is exclusively reserved for an EN visit performed on the day before or the day of a major procedure, meaning a 90-day global period that results in the initial decision to actually perform that surgery. Think of it as the decision for major surgery modifier. So the absolutely crucial contrast you need to remember here is between Modifier 57 and Modifier 25. Imagine a patient comes into the ED with severe abdominal pain. You run a high-complexity workup and make the call that they need an emergent appendectomy today. You would append Modifier 57 to that E&M visit. Why? Because an appendectomy is a major 90-day global surgery. The big rule of thumb, never ever use Modifier 57 for a minor 0 or 10-day procedure. Minor procedures get Modifier 25. Major procedures get Modifier 57. Simple as that. So with all these overlapping rules, timelines, and super nuanced documentation requirements we've just covered, you kind of have to step back and ask yourself, is your current documentation accidentally painting a giant bullseye on your practice for a compliance audit? And that leads us nicely into Section 5, Top Audit Red Flags and Compliance Guardrails. Look, knowing the definitions is honestly only half the battle. Defending against denials and staying compliant is the ultimate goal here. What you're seeing now aren't just theoretical errors. These are the absolute most common ways clinics literally leak revenue and invite heavy auditor scrutiny. A huge red flag? Billing routine post-operative wound checks or suture removals with Modifier 24. Another massive trap is relying on your electronic health record to just auto-attach Modifier 25 to all minor procedures without typing out a distinct medical decision-making note with documented time. And of course, accidentally applying Modifier 57 to minor 0 or 10-day surgeries, or failing to link the proper separate diagnosis to an unrelated E&M, or just stacking modifiers without real medical necessity. Don't fall into these traps. I highly recommend keeping this comparison matrix handy. Treat it like your clinic's ultimate cheat sheet. Whether you're using 24 for a totally new problem in a post-op period, 25 for a separate E&L alongside a procedure, or 57 when you make the call to jump into a major surgery, having robust documentation that practically screams, this is a separately identifiable service, is for sure your absolute best defense. So, master the modifiers, protect your hard-earned revenue, and always, always let the clinical documentation drive your coding. Leave with this provocative question. If a compliance auditor looked at your same-day procedure notes right this very second, would your revenue actually survive the test? It's definitely something to think about. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.